we're good to go. Okay, so Dan, tell me about what you do.
So I'm a neurologic physical therapist. I work at a hospital in Pomona called Casa Colina. And so I have a board certified specialty in neurologic physical therapy. And my role is working with people who've had neurologic injuries. So spinal cord injury, brain injury, stroke, chronic injuries as well, multiple sclerosis, Parkinson's disease. And then I also work with vestibular disorders, dizziness. Basically anybody who's having neurologic dysfunction will come see me.
Where there's like some thing that's happened where they go, something's wrong with my brain. It's not
Exactly.
just I'm experiencing, let's say, something like depression or anxiety where I feel some different common feelings. These are things where usually the person's coming in, something is significantly going on from a neurological perspective. So like what's like a common complaint that they might come in with?
That's a great question. I mean, we can get patients across the spectrum of severity. So if, for example, if somebody's had a severe brain injury, right, we would call that a disorder of consciousness. And so, I may work with somebody who is minimally conscious, somebody who's really not able to do anything for themselves, in which case it's a lot of educating the caregivers on how to care for their family member or their loved one, and how to help them be optimally supported, right? All the way to perfectly healthy adult comes in with dizziness, and we work on stability strategies. We work on managing the symptom intensity, habituating themselves to that dizziness. It just depends.
Yeah.
But anybody kind of across the neurologic spectrum can come work with us. And our role as neurologic physical therapists is similar to the physical therapy you might receive, if you went to an outpatient clinic with an injured shoulder. Of course, we use exercises as a medium, as a tool, but we're also really relying on the neuroplasticity of the brain, the ability of the brain to change. And so that would involve teaching them new patterns, teaching them new strategies, and helping their brain work around whatever that injury is. And that can look a lot of different ways.
Okay, neuroplasticity, you're counting on their brain's ability to heal itself. Are there ways that you promote that? Or how do you think about neuroplasticity as, like, let's say that's the foundation of healing, and you need that to be there for a person,
right, for
them to heal. What do you think about that as something that you try to help promote in some way?
Absolutely. I think because the types of patients that I see are so diverse, the approaches are going to be different. But I think the most common example would be a stroke, for example, right? So if there's a stroke in the middle cerebral artery, that person then will become paralyzed. There's an entire portion of their brain that's shut down. And so there is all kinds of crosstalk that happens in the brain, these advanced neural networks that speak to one another and interact. So are we able to enhance healing in that part of the brain that's been affected? So in other words, if there are portions of the brain in that region that remain effective, can we maximize their use? And then also, if there are areas around the brain that can serve a similar function, can we take advantage of those? So for example, a lot of the movement in our body is innervated bilaterally. So what I mean by that is if let's say the left hemisphere of my brain has been affected by the stroke, there is a small but meaningful portion on the right side of the brain that can facilitate movement in a way that's been lost. So how much can we leverage that? And we use those principles and build from there. But of course, we're also incorporating musculoskeletal principles, right? So for example, if somebody's had a stroke and they can't properly walk, can we work on the mechanics of their walking? Can we have them utilize their hip muscles more to stabilize? Can we put them in constraints that will help them improve the quality of their movement or their walking?
Wow. Yeah.
Yeah.
So to use an analogy there, it's kind of like if you had a bridge and one of the struts was broken, removed, something like this, you might look to the nearest strut that's close to that one and go, can this one be fashioned to bear more load, to help the bridge still hold weight, right?
Yes.
That might be a good analogy, maybe but you're talking about like neighboring capacities that you can build and borrow from in order to help this person still be functional in their everyday life.
Absolutely.
Am I hearing this right?
Yes.
Yeah.
And so that would be from the neuroplastic perspective. But then there are other things, because I really see my role as a physical therapist to be focused on quality of life and independence. And so what I just described would be the ways in which we want to restore function. But at the end of the day, my goal for patients is for them to be as independent as possible. And so we're also looking at compensatory strategies. So looking at the assistive device, for example, a cane, a walker, a rollator that would best serve them. But then also really making sure that we are addressing the things that are most important to them. And so what I mean by that is, I have a patient right now who had a spinal cord injury. But before this, he really liked to fish and he really liked to hunt. And so one of the targets of my therapy is going to be, well, how can we get you back fishing? Let's figure out a way to get you on a boat. Let's get you deep sea fishing off the side of a rig in the Pacific, because that is still very much considering what would be quality of life for him, right? It doesn't mean that I fix his spinal cord injury and he walks himself onto that boat. It means, how can we still get you doing the things that you care about? And that looks a lot of different ways for a lot of people. Yeah.
That's wonderful. And something I imagine is that when you put that kind of goal at the end of it, that means something to them like that even if they don't end up reaching that goal as they wanted to, or in the way that they wanted to, you're still helping them take the first steps much more easily than if they didn't have that goal, let's say.
Right.
At least that's what I picture when you say that, of like, it's not just putting a pie in the sky thing of like, oh, what if it's also helping them actually make those steps happen in order to have like a goal that's, you have to have a carrot, it seems like, that is meaningful enough to actually go through the incredibly intensive work that I imagine it is to try to regain function. I'm picturing the feeling on a more mild case of like somebody, using the right hand to write and then having to switch and forcing themselves to try to write with their left hand. Everything inside your brain wants to keep putting it over here or doing it in the old way because it requires so much more energy to do it this way. Right. And if you're going to do something like that, it seems like you have to have a meaningful goal in order to encourage some kind of brain plasticity or some kind of way of motivating oneself to go through something like this.
Absolutely. Absolutely. And it's funny that you mentioned writing with the other hand, because that's a very common strategy of recovery for people with stroke. If somebody's right hand dominant and their right side becomes paretic after a stroke, one of the interventions that's commonly used is to practice writing with their right hand. And it's so much more laborious and it's so much more difficult. And it's so much easier to just learn to write with the left hand, but we really want to encourage use. There was an important paper published in 2008 by these two speech therapists, Klein and Jones, who talked about the 10 principles of neuroplasticity. And one of them is salience, right? How important is this to you?
Yeah.
So in the example that you gave, if I want to write with my right hand again, let's talk about why that matters. If you have an older adult, they might want to sign their checks. They might want to be able to sign documents for themselves. When you've had an injury like this, if somebody takes over as your, primary care provider, or if somebody is chosen as to make medical decisions on your behalf, that can feel a lot like your independence is being taken away. So if you imagine being able to sign your own documents and being able to claim ownership of the decisions, and especially in regards to your medical care, I mean, that's a huge thing. And these are all the ways in which we try to make it more salient to people. And, I think about kind of the mental, or I should say, the emotional, the social, the psychological components of this, especially because so much of what I do needs to incorporate those things. It's interesting in that I have a lot of patients who will come in with what seems like a strictly physical problem, and yet when you kind of explain it to them and help them understand better, you try to get them to recognize, yes, I want to get your body moving better, but the things that you're going to need to live the best quality of life possible are also going to incorporate those mental elements, you know?
Yeah. It's interesting. When you said they want to be able to, sign their checks or something like this, the example that came to my mind is they probably want to be able to write a note to their grandkids. They want to be
Right.
able to write birthday cards or holiday cards. And,
Right.
when I picture that person, whether it's someone who's younger and who's had a stroke or an older person who's losing some kind of functionality, I picture them immediately when it gets hard, immediately I imagine them going, why do I have to do this?
Mhm.
Why is this, like you said, why is this important to me? And the richer that goal, that imagined state is for them of what they want to be able to do again, I imagine that the more effort they're willing to put behind doing it, especially when it gets hard,
Right.
I wonder, my own, my wife's grandparents, they've said things out loud where they're wonderful at like staying active, staying physical. And, she'll be like, oh, I tried out the new swimming class at my gym. And we're like, you swim? We're like, well, we're doing yoga together. And they're like Idaho farmers, right? Like,
Oh my gosh.
this is like very new for them.
Right.
And the thing they say is like, we want to watch our grandkids graduate from high school. We need to be there.
Yeah.
They have a sense of I'm needed,
Right.
like, but that is organizing all of their behaviors under that is
Right.
all organized around this thing. But I think there's something that speaks to me when you say it of like, it's not just about do this practice,
Mhm.
because as soon as it gets hard, nobody wants to do that. Everyone's going to want to give up the first chance they get.
Right.
But it's about, I imagine, establishing, like you said, some kind of meaningful functionality that is worth everything for them to try to achieve again for
Right.
themselves, like the fishing.
Right.
Yeah.
You're actually making me think of, there's an absolutely excellent commercial, and I wish I could cite it directly, but it's a commercial in which it's like summertime, and you see a shed, and this older gentleman walks into the shed in the back. He picks up a kettlebell and he starts doing kettlebell lifts just in the middle of the day. And there's no context, right? He's doing the kettlebell lifts. His daughter walks past the window, sees him, gives a little smile, keeps walking, and he does his kettlebell lifts. Fast forward, it comes into fall time. Again, he's doing these kettlebell lifts, raising it up overhead. And then it gets towards the end of the commercial, and there's snow outside the window. And now he's no longer in the shed. He's in his home. The camera pans, and there's a Christmas tree. And he takes his granddaughter, and he lifts her in the kettlebell lift and raises her up to put the Christmas tree, to put the star on the Christmas tree. And that is just the most perfect example of how to build a healthier society in my mind. It gives a great example of consistency. The guy does it every day. Repetition, salience, again, that importance to him. Right? Going back to that paper I talked about, neuroplasticity is also dependent on intensity, right? He was doing it with an amount of weight that was actually challenging.
Yeah.
And at the end of the day, he gets to do this incredibly special thing with his granddaughter. And so I think about that commercial a lot in the work that I do, because that's really what this is about, is how do I make this important to the person that I'm working with? And it's funny too, because, I think that within our society, I think we tend to separate the mental state from the physical state. And I think this goes back into a lot of things, if you think about even like Plato, Plato, Marcus Aurelius, like early philosophy, Rene Descartes, like this idea that the mind and the body are separate. Right. And I mean, unfortunately, that kind of penetrated into our society in a way where, throughout the 18th and 19th century, people just kind of wanted to believe that the mental state and the physical state were perfectly separate, that the mental state could dominate the physical state. But as we're coming to understand with new technology, that's just not the case. We would see these people with these physical manifestations of these mental conditions, and and the reason I'm kind of bringing this up is because I am thinking about, how you and I interface. Where do our jobs meet?
Mm-hmm.
And so we would have people with, different mental states, different mental conditions, who would come in with physical displays, and we would call that conversion disorder. We would call that hysteria, and we would basically write it off. We would say, well, clearly you've demonstrated a moral failing. Clearly there's something just wrong with you. We're going to put you in a home in the mountains and just forget about you.
Mm-hmm.
But now we're understanding through modern imaging technology and all of these things that there are very real interactions between the mind and the body that require treatment in both senses. And I don't know if I'm getting off topic.
Yeah,
here,
no, that's great. There's interaction between mind and body and how it's been separated, right, over time. You're mentioning, Plato, some of these early, philosophers who've influenced the way we think about the world. The thing I would add to that, I think, when you say that, is that the way that I view it, at least, is that those kind of philosophers weren't so much top-down informing how we ought to think about our bodies, but were maybe kind of like emergent reflections of how the culture or the way that people are set up have been seeing their bodies, have been seeing themselves. I think it's in all of us to try to remove ourselves from our own mortality, our own bodies, and that these philosophers seem to resonate with us for a reason. You know what I mean?
Right.
Where we wanted to feel like we're separate from our bodies, right? We wanted to feel this way. The reason I say it is because I think that, well, I guess to add something else there, I think the reason that some of those philosophers, if I understand it right, of like came to power then, or it came to prominence then, was out of this urban environment, let's say, where people are more disconnected from their reliance on nature, they don't have to literally forage for their food anymore. They have free time, and they like this idea of feeling separate, and they conflate nature, let's say, with chaos, unpredictability, pain, death, and that as long as we kind of stay with our symbols as a culture, or our way of being, and paved roads, buildings, things like this, now we feel safe. We feel secure. And there's this mind-body disconnection there of being in a thought world and things that are not based on my basic meeting of my everyday needs all the time, that creates some kind of different paradigm shift that ends up, all to say that people like Plato or Aristotle, whoever, ends up coming back to us and saying, creating this idea that we are separate from our bodies. The reason why I think that's important is I think that it's definitely something that is emerging now too, with things like AI, with things like internet, with all these things where we associate ourselves with things that aren't based on our physical being in the world, and we end up having this idea of my mental world is separate than my physical body, or even this thing that I think Andrew Huberman is great. I think he does some great stuff. However, I do think he has this assumption built in there that the real task is that I need to proactively do something to my body in order to affect change, as opposed to seeing my body is wanting to do certain things and I need to listen to those things. I need to figure out with wisdom how to take care of what is emerging in myself. I think it's a little bit more of a connected way of seeing oneself in those environments. But I think you're right though, that there's this huge gulf between something physically happening in my body and something mentally happening in my internal world that really sets us up for I guess not growing, not healing, those kind of things.
Right. That's a very interesting perspective, and I hadn't thought of it that way in regards to the ways in which we kind of culturally reinforce the separation. And that's very true, that we've almost retreated into a mental world.
Mm-hmm.
If we think about social media, for example, being the most obvious, there's definitely this idea of we can live within the mind, we can exist within the mind, and we can separate ourselves from the body.
Mm-hmm.
And it's fascinating to think about. We can place somebody in front of a television for 10 hours.
Mm-hmm.
They can binge watch a Netflix series, and the body is very stagnant through that entire 10-hour period.
Yeah.
When before that would have been inconceivable.
Uh-huh.
Inconceivable. And that has to do with just the amount of available dopamine and serotonin at all times. So that's really fascinating. And I'm sure that we're seeing impacts in regards to that. So one thing that's interesting for me as a physical therapist is that I have absolutely seen patients. I treat patients regularly, and I'm currently treating patients who come in with, physical manifestations of these mental states. And so there is a condition that I treat semi-regularly, and it's called functional neurologic disorder.
Mm-hmm.
So basically, functional neurologic disorder is a condition in which patients have some kind of sensory or motor symptoms. Maybe it's weakness, maybe it's shaking or tremor, maybe it's ataxia, discoordination, maybe it's dizziness, instability, that can't be explained with normal neurologic testing, right? If they do a simple CT scan, there's nothing that shows up. If they do a simple MRI, nothing shows up. If they do a test of the person's muscle integrity, nothing shows up. And yet the person is saying, well, I'm debilitated. I can't do the things that I need to do. And so not all patients who have this condition have a pre-existing psychological comorbidity, but many of them do. And it expresses itself in all kinds of ways. So, I'm trying to think of an apt example. I had a woman who had a infection of her inner ear. So it resulted in horrible, overwhelming vertigo. The room was spinning. She felt nauseous the whole time. She couldn't even get herself out of bed. And for several days, it was like this. As the infection kind of infiltrated, her immune system cleared it out and eventually got rid of it. But for those, 10 days, it was horrible. It was awful. And this experience was so traumatic for this woman that long after it had gone, months after it had gone, she came in to see me saying, I feel unsteady. I feel off balance. I am so worried that if I turn my head the wrong way or bend over, I'm going to get dizzy again. I'm going to fall over. Meanwhile, when we did our actual testing of this woman's balance, perfectly fine. Perfectly fine. Right? But even during the balance testing, she became so overwhelmed with emotion that she started to cry. And so what we do in these situations is, what we would call that's a functional neurologic disorder, like I described. This would be functional dizziness. And there's another term for it, persistent postural perceptual dizziness. And so the way that we treat this condition is basically through CBT principles, right? Cognitive behavioral therapy. So physical therapists were given kind of a limited exposure. There are some tools that I'm familiar with out of the CBT playbook. And so graded exposure is one of the main things that we do. And the term we use is habituation. So I would have this woman not even bend down onto the ground. I would have her pick something up from about a foot off the floor. And I had her do it, to repetition, right? Coming back to those neuroplasticity principles. And again, she became very overwhelmed with emotion. Like she started to cry and be like, I'm not sure if I can do this. I don't know how to do this. And so a lot of it was me, obviously, trying to create a safe space, trying to show compassion, make sure that I was giving her the appropriate amount. I didn't want to overwhelm her. But, going through these things again and helping her understand that infection of her ear had come and gone. It was done. What remained instead was a new problem, which was her brain had become so sensitive to changes in motion, so sensitive to changes in position for fear of the repercussions that it was limiting her.
This is a fear response.
This was a fear response. This was fear avoidant behavior. And so she's one example. I have several. But for all of these patients, coming back to where you and I meet, why I need you is patients like this really do need a mental health professional. And there is that mental element, right? I can address the body. I can provide physical interventions. I can provide very limited mental interventions, but they really need somebody who understands that emotional mental process as you do.
Yeah. And to see that physical process as an emotional process too, what was happening in her ear was not an emotional process. The amygdala was please correct me or elaborate on what the neurology that I know here, but that her amygdala was amplifying the signal from her ear out of fear. The way that I understand the limbic system is that it's like kind of like a prioritization system. It's how important is this to right now? And that when it really puts like those 3 exclamation points behind the email, you know what I mean?
Mm-hmm,
like
right.
When it really does it, when it tags it as this is of vital importance, we feel it in our chest, we feel our whole system change its pitch, change its tune to meet that prioritization of that information. And when she has something like this going on with her ear and it gets tagged like that, something that can be a problem, I'm sure you're aware of, is that once it becomes somatic, it becomes really hard to change. It becomes ingrained. Once it becomes a physical symptom, let's say somebody has stress, right? And it becomes back pain from their stress, it becomes that much harder to treat. And that's why I say that it is an emotional thing at that point, it's not just that they need to talk in therapy. They actually, to heal the emotional thing, they might actually need someone to walk them through doing the balance exercise and showing them that they're safe, showing them that they can balance. I'm wondering how much, when you said that she started to cry, about how much you saw what you were doing with her as helping her through something emotional, and how much you see that in your patients when you're helping them with something physical, how much it feels to you like you're helping them emotionally with something.
That's a fascinating question. And that's a very good point. Absolutely, I see the work that I do as helping people process physically. And it's different for everybody, right? The example of the woman who became very tearful, that was a very emotionally charged condition. When I think about helping people emotionally through it, I'll give you another example. I had a young woman come in. She was like 35, 36 years old. And she comes in and her whole body is shaking nonstop. She can't even focus her eyes, right? I immediately saw this woman and I was concerned. I was concerned that there was something happening within her brain, some sort of centrally driven condition. And I actually referred her back to the neurologist because I was very concerned. Now, fortunately, she had some excellent neurologists who were diligent in their workup, and we concluded together, no, this is a functional neurologic disorder. This woman is having a functional tremor, functional ataxia related to her mental state.
Wow.
Yeah. And so a lot of her treatment and care was reintroducing her to the things that she was afraid to do. And making sure that it was a safe environment, explaining to her the task, but then always making sure that when she did it, I was clear, wow, you just did that. That's amazing. How do you feel? Do you realize that you just, reached, that you just were like turning in tight circles, reaching way outside your base of support, doing all of these really hard physical tasks. And you just did that for the last 2 minutes without getting dizzy. Wow. That's amazing.
Yeah, yeah.
And she was able to internalize that. And fortunately, her recovery was excellent. And prognostically, the majority of people who have functional neurologic disorder will improve. They will get better, which right off the bat, if someone comes in and they have this, I can tell them, look, prognostically, you're probably going to get better. And that alone meaningfully impacts their recovery. So for her, when we came to the end of our sessions together, I mean, I was challenging this woman the way I would challenge any 35-year-old.
Yeah.
I mean, I was basically giving her exercises that a 35-year-old athlete does. And when we finished, I tried to impress upon her, like, this condition is something you used to have. This is something that you don't need to carry with you moving forward. This doesn't have to be your identity. This doesn't have to be a part of you. In the same way that we get over other illnesses,
Right.
if we get over a cold, if we get over, you know, other conditions, like, for example, that woman with that inner ear problem, the vertigo, when we get over those things, we move past them. And so I wanted to impress upon her, this is something that you've gotten past, you know?
Wow. So what would you say about what is the actual healing that's going on there for her? What is actually changing for her?
Right. That's a great question. I think for her, the healing is being able to re-educate the brain, right? Because what's happening is we think about it kind of like a computer, right? So if we think about early medicine, we could only dissect a body, look at the parts, and say, clearly these must have different roles. And so think about that like computer hardware, right? But now that we're understanding the brain more intimately and nerves more intimately, we can think about it like software. And so for this woman, there was a software malfunction, right? The computer was working fine, but the communication, the software was off. And so in my mind, all I did is just help her reprogram the software by showing her that the things that were hard and scary and difficult were going to be okay, that she was going to be okay through these things, that she could get through this and come out on the other side and be okay. And
wow, just when you break it down like that, you know, you kind of zoom out for a second, you see these two brains working together. You know, that she's borrowing something from you. You know, she's borrowing your ability. This is what Daniel Siegel would talk about as like, you know, this social synapse that's going on. You know, she's borrowing your capacity to have some kind of, let's say, hope, or you can think about like the anterior mid-cingulate cortex, like this feeling of you can get through the storm. It's going to be okay. This is kind of dopaminergic kind of channel that she needs to like borrow from you of like, I've been through this before with other people. It's going to be okay. You know, like do this, do this, do this. And as you do that behind the scenes, like her fear response is going down as she sees that she's able to be functional. She's able to actually do something and receive feedback. And she sees that she improves. Now her fear is that much less and she has that much more confidence that she can do the next piece of it. But there was nothing that needed to change about her musculature with like the tremors or anything like that.
Right.
Also, I don't know that it would have been the case that if you sat her down and talk to her about her fear, maybe with a really trained therapist, you know, they might have been able to get to some of the same places. But if that therapist was to get to some of the same places, they probably would have done something similar to what you did, right? Of being able to like help her come closer to the thing that she's afraid of and go, it's okay. It's going to be all right. I think that this is like a resounding theme that I hear with some of our other practitioners. I don't know if you listened to our one on the pelvic model, but she was,
yes, absolutely.
where she talks about literally
Rachel Dayoff.
Yes.
Yeah.
Where you put pressure on the pain point, the place that you don't want to have touched at all, the place that you keep wanting to avoid, wherever the pain is. If you're willing to consciously put pressure on there, and just take a breath, I'm still okay. I'm still alive. I'm still good.
Right.
Now let's do it again. Now let's push harder. You know, it's
amazing.
That's what you did with her, you know, right?
That's a really interesting perspective. I hadn't thought about that. The idea that she was basically subconsciously leaning on me. Am I understanding correctly?
Yeah.
So she's subconsciously leaning on me to basically provide that environment, and she's borrowing from me using my wisdom and my experience to recognize that it's going to be okay. It's really funny that you say that, because with a lot of my patients, one thing I like to do is, I mean, when they thank me, I like to say thank you. Of course, I'd like to be gracious. But one thing I do like to say is that when a patient is kind of celebrating their success, I like to say, they'll say, thank you. And I say, well, actually, I didn't do anything. You did all the work. I just bossed you around. And so, my intention in that is I want them to feel that they have that ownership, that they have that self-efficacy to move forward. But maybe one way to frame that based on what you're saying is, okay, the work's been done. The success has been met to some degree, right? We've had some success. And now my intention is to pass the buck and say, you've used me for this. I've given you guidance this far. The rest is up to you, and you can do this.
Right. So for this patient, what I might ask myself as a psychologist is, what was emerging in her that made her tremor in this way in the first place? Why did this happen to her, right? As opposed to somebody else.
Right.
And we could go, oh, it's genetic, this, and it's like, likely there was something that was being expressed that needed to be expressed. And often the things that we experience are like, we're re-experiencing from the past. We are remembering, something that has happened to us. Sometimes this is, again, how I see that handoff happening, is that like somebody comes in and there's a life event that sparks something falls apart, something falls, you think about someone with like some symptom emerges, and let's say it's around a life transition, the birth of your child, marriage, divorce, all these things. And there's more weight put on the bridge, so to speak. There's more stress put on your brain, on your system, on your body. And suddenly a symptom emerges, like the tremor.
Right.
And it is pointing us back in that moment to reevaluate something that is painful about the way that we experience the world, the way we experience ourselves, the way that we've been treated, that is now untenable. We can't survive with this any longer.
Right.
And so the symptom is a cry for that kind of healing. It's saying, I'm not okay with this anymore. The dam has been breached. I can't hold this water like this anymore. Right. But that's a little bit of what I see when I see something like this, about like a somatic thing coming up like that.
Right.
I see it as such an important transitional moment for them, a liminal moment for them in their life, where their body is having a chance to cry out for help. And they may start by just needing to address the physical symptom and then see, okay, I can get through this. I can cool down.
Right.
Yeah.
That's really interesting. And I think another facet of that as well is I'm a big believer in doing what works for you. And what I mean by that is, we're talking about the state, right? You've just described somebody who finally has these physical manifestations of the symptom. The dam has over flooded, and now they're seeking help. And what's interesting is there is a diversity of personalities that come to me with this exact same problem. It is not one phenotype. And so different people are going to seek help in different ways. I know that you had on a somatic therapist. Yeah. I know that you've had on somebody who addresses chronic pain. And so all of these people have different approaches. And even within the realm of somatic therapy, I know that there are different varieties.
Yeah.
And so I think different things are going to resonate with different people. There might be people who do not gravitate towards me, but gravitate heavily towards a somatic therapist, and vice versa. There are people who will gravitate heavily towards psychological care for these conditions or physical care for these conditions. And I really do believe an important part of this is finding the person who you resonate with. There's been a lot of data that's been published about the importance of a therapeutic alliance, right? The amount to which you connect to your healthcare provider really meaningfully impacts your prognosis. And so I've had patients who I gave them my tools. They said, this isn't working for me. I said, absolutely, best of luck to you. I wish you all the best. And I've had patients who leaned on me and said, you're the only one who's helping me. I refuse to go to any other healthcare provider. I just want you, which I have conflict about because I don't agree with that mentality. But it's just really interesting to see. But I think the work that all of us are doing collectively is starting to enter the social conscious. And what I mean by that is these patients really need holistic care. It's not enough to just see me. and it's not enough to just see somebody else, right? For certain conditions like this condition, we are starting to incorporate the healthcare team, but I think I'd like to believe that we're moving in this direction, especially in a world where we are so completely overflooded with information every second of every day.
Mm-hmm.
It's getting really hard to ever justify that one person has all the answers,
Sure.
right? No one can say, I have all the answers.
Mm-hmm.
And so we're starting to recognize, no, like this is a team
Mm-hmm.
effort, you know? But with these patients, I definitely try to encourage self-efficacy so that they're the ones directing their care. I want to be your coach. I want to be your teacher. I want to tell you what I know and have you lean on me in the moments that you need that. But I'm not the one driving the car, you are.
Mm-hmm.
And I think that's also an important part of healing. I really value self-efficacy as a quality, and I try to bring it to my patients. It's definitely one of the most important things for me as a personal value, that I want to give more people that sense of self-efficacy, the sense of, well, I can move forward from here. And that can happen across a lot of the conditions that I see in my clinical work. But if I can help them take ownership and move forward in a way that feels right to them, then I feel really good about it. Like, I'll give you another example. I had a woman come into my clinic. She had an injury at work. There's definitely a phenotype where people get injured at work. There's a workman's comp case. There is a lot of money on the table. There's a lot of pressure from the lawyers to make sure that they, stay unwell, basically. Because if they look like they've recovered, then there's no settlement. And so it encourages patients to fully embrace being injured. Victims,
Yeah.
And so this woman came in, and it was, still early morning, but she had very thick, dark sunglasses on. Everything hurt. 10 out of 10 pain, 9 out of 10 dizziness. She had been seen at one of our other departments where they were provided with intensive rehabilitation. Neuropsych was available. All kinds of therapies were available. And this woman was still reporting this like severe, debilitating pain. And we sat down for our evaluation, and I was taking my intake and trying to understand. And what she said to me, she said, you know what? None of this is working for me. I think I might just kind of figure out my own thing, right? Meanwhile, she'd come to me, for the help. Like I was the official, right? And she was like, I think I might do my own thing. And I was like, that sounds great. That sounds excellent. I would really encourage you to do that. Find the people who work for you, right? Because then she can start taking ownership, and then she can start feeling like she's going to figure out how to move forward.
How'd she respond to that?
Limited. Because the trust hadn't been built, I think.
She might have been looking for something emotionally there,
right.
Some kind of reactivity there from you, you kind of wonder if it's, and not to say, I obviously don't know this patient, but it can be some kind of thing where they're looking for you to go, oh, I can do better for you. I can do more for you. That the more she crosses her arms, the more that you feel compulsion to baby her, help her, and what you're saying, and I think that's a wonderful response, which is like, great. Okay, well, how can we do that for you? Let's get you to somebody who can do that for you. In fact, we might be limited here in what we can do. Because as soon as now the potato is in her hands, as soon as she has the check to sign, now she's going to feel differently about it. As soon as, like all to say that there is an incentive, like you said there about the money with the settlement, there's an incentive to stay disempowered. Because as soon as I take responsibility into my own hands, now I can feel guilt. Now I have to take care of myself. Now I'm not going to get emotional connection or sympathy from other people. All those things go out the window the minute I say, this is actually my responsibility, and I'm going to have to do something about this.
Right.
And she was trying to do the same thing with you, kind of, like, I don't think this is working for me. Instead of, she could have come to you and said, I want to do my best here to make sure this is a success. What do I need to do to be the best patient, that I can be? That kind of attitude, though, takes a lot of, I think, emotional strength. It
Yeah.
takes some kind of security there. That sometimes I think there's these payoffs that we have that can keep us in like a more victim kind of
Right.
mindset about those
Right.
things. Nothing is working for me,
Right.
but yeah.
And I think that for this woman too, I think about it a lot as like the systems that we're a part of.
Mm-hmm.
And I really think that there are so many systems that encourage her to stay in that illness mindset.
Yeah. Well, there's a dollar amount attached to it in her case, wasn't there?
Exactly.
Yeah.
Yeah, there's a literal reward to staying in that mindset. And so, I believe that for the people who can claim self-efficacy, I think that their lives become better. I think that the quality of life is much higher. She may not have the settlement money, but she'll have personal satisfaction. All these things that I really believe in. But I thought it was excellent when she said, "I'm not sure this is working for me. I want something else." Because maybe, someone who does somatic therapy could be better for her. Maybe someone who does acupuncture could be better for her. Maybe somebody who does chiropractic could be better for her. Now, that being said, without getting too far off the rails,
Mm-hmm.
I do believe in a moral obligation as somebody who has received a large amount of education to try to educate people as best I can in regards to what I know. So what I mean by that is there are certain providers that provide care that isn't evidence-based and that doesn't have its roots, its support in Western medicine. Western medicine is what I know. This is what I'm qualified to speak on. So when something doesn't have support in Western medicine, I feel obligated to explain that. That doesn't make me right.
Uh-huh.
There are tons of Eastern interventions that have really helped change people's lives and have made their lives better. But there is the consideration of placebo effect, and someone may help you feel better in a way that is not based around what they do for you, but how they make you feel. And that's not always helpful. And there are sometimes risks involved in that. That may not always be safe. So I do try to educate my patients as best I can on, okay, this makes you feel better. Have you considered this other thing, which could make you feel better and has more evidence to support it?
Is this kind of, it sounds like that's also in this bucket, like you said earlier, of dependence. Is that part of what you can kind of tip your hat or kind of give a yellow light kind of like for you when a patient might mention some kind of alternative therapy? Is there a party that sometimes wonders, are they just getting in a dependent relationship with something that's not actually curing them or helping them heal? Is that part of it when you think about it?
Absolutely. Absolutely. I am always wary of models of care that say you must come to me every week for the rest of your life.
Uh-huh.
I am always wary of models of care that say you are fundamentally damaged. There is something inherently wrong with you. And I am wary of people who talk a big game, like people who are trying really hard to convince you that what they do works.
That there's some kind of magic to what they do. That
100%.
You come in to see me, I just know what to do. I'm special that way with you. I kind of,
Right.
but they can't describe to you what's actually, this is a vibe that I get sometimes with clients too, when they talk about certain things. And it is hard because like you, I mean, I really think that if it's something that works, you ought to be able to explain it. And that a patient deserves it to be explained to them, whether it's from you about why you're doing certain interventions with people, or whether it's by this other practitioner. I always encourage them, can you ask them about what they're doing and how it's working, because they deserve an explanation in those cases. It shouldn't be magical when they're going to somebody else or yourself. It shouldn't be like, oh, I'm doing this magical thing called psychoanalysis or depth therapy. I ought to be able to justify what I'm doing from fundamental perspective, from the fundamentals of what's actually happening there. And I expect that of myself, and I expect that of the care that they receive from somebody else.
Right.
But yeah, I feel you on that of like that there can be this trap that you can observe some people going to where they feel helpless. They feel like they're looking for anything that's going to give them some kind of either shortcut or or not even shortcut, but just the thing that's finally going to work for me. And then there's certain kind of practitioners who can capitalize on that kind of sense from a person of their desperation.
Right.
Sometimes well-meaning, sometimes not, but
Right.
It's kind of a difficult thing.
Yeah, absolutely. And one thing I will say is I have had patients who struggled to find something that worked for them and really were struggling to pull themselves out of their condition. And they ended up finding something that really worked for them. I've had patients who said, well, my Reiki healer really helps me feel better. And I always walk out of there feeling better. And so my question that I typically ask people is, do you enjoy it? Do you find that it's helpful for you? How do you feel when you go there? And so, if they express positivity, if they're like, look, I was really struggling and now my Reiki practitioner is really helping me a lot, then I don't want to burst their bubble. If you feel that it's working for you, if that's the foundation that you need to get started, and now you're seeing me because you feel that you've gotten to that place, that's fantastic. And I'm not gonna disrupt that, right? But I've also had other people come to me and say, well, I go to my chiropractor and they, make my neck pop like bubble wrap for 30 minutes. And I say, well, what does that do for you? And they're like, well, it makes me feel better. Did you know that massage therapy could also make you feel better to that same degree? Did you know that there are also exercises and stretches that you can do that would make you feel better to that same degree? Have you considered doing those instead? Right. Just as a way to elevate.
Right. And so what they're going to say back is, if they were to, let's say, be honest, is, but I want someone else to do it for me. Right. I want someone to hold my hand. I want someone else to tell me that it's going to be okay. And that just watch, I'm going to do this thing. It emulates like the mother-child kind of care and interaction. Right. That if some of us are deficient in that kind of space emotionally or relationally in our lives, we don't have enough friends or partners or parents who can speak that tone to us, it's going to be all right. I've got you. It's safe. Right. If we don't have that, where are we supposed to get it? Right. And some people are willing to pay and they will blind themselves to the fact that it's magic. Right. That isn't really doing much physically. They'll blind themselves to it because they want to believe that there's someone who's going to care for them, you know? And so I feel two ways about it. Part of me goes, stop going there. Stop, because I don't like the idea of someone taking advantage of a person in desperation, of course, or capitalizing on that or thinking of themselves in some narcissistic, magical way for their patients. On the other hand, I feel for that of like for someone living alone, let's say, where they go, I like the fact, if they're to be honest with themselves, I like the fact that I go in there and I know my person is going to be there. And they're going to give me attention. They're going to be physical in some way that makes me feel safe and good. And I go, I get it. I get that part of it. It's hard. Yeah.
It's absolutely, it is. It's really a challenge. And it's funny because what you're describing is actually making me think of somebody that I'm working with right now who has that condition, functional neurologic disorder. She has the functional dizziness. And so she's been coming to see me for 8 months. And we've been working together, and my background in Western medicine, my understanding of my field makes me understand that my ability to help this woman is very limited. I have very few things that I can do that are going to be useful to this woman. The primary reason being that she continues to limit her own behavior. There's still fear avoidance because she feels very anxious. She gets numbness on the top of her head, and she's so worried about what that means, even though that's probably, again, another sensory expression of this mental state. She doesn't want to go for runs. She doesn't want to ride her bike. She doesn't want to go to church. She sits in her house alone for large portions of her week. Wow. And so she's been coming to me, and I did what education I could. Her benefit has become very limited. And I spent time and I sat her down and I explained, look, there are mental barriers to what I can do for you. Yeah. And I think that I give you homework and I send you home and I ask you to do these things, and we haven't had much success. And so I think if you could work with a mental health professional to change that state, to feel more in control of your life,
Yeah.
I think you could come back to me and I think we could do awesome things.
Mm-hmm.
I think we could get you back to everything you want to do.
Mm-hmm.
But we need to address that first.
Yeah.
She got very upset with me. There was a resistance. There was a refusal.
Because
she felt that I was helping her. And
okay, well, this is where I go,
yeah.
What is the numbness in her head doing for her?
Right.
It's making her, it's giving her attention.
Right.
It's helping her have some stability in her life. It's being, paid attention to.
Right.
And not to say this is her, but patients like that will form an attachment based around their symptom where they go, as long as they continue having this symptom, I get to come in and see you.
Right.
And then I feel good,
Right.
I feel good because I feel bad. Again, this is like the kid who only gets attention from mom and dad when they're crying, know? But as soon as they do something good, or as soon, or as soon as they're independent, mom and dad are nowhere to be found. You want to have an experience as a kid where when you go to the store by yourself or when you play on yourself, your parents go, hey, tell me what you did today.
Right.
I'm so proud of you. That's amazing. You did that by yourself? I love that. Like I'm still engaged with mom and dad even in that. But you think about the other kid who's like always has to keep, I see these kids in Target all the time for whatever reason at Target.
Okay.
But like the kid who's just always, they're not quite crying, but they're not okay. They're like, you know what I'm talking about? And they're just holding onto mom's shirt, and it maintains an attachment. They feel like if I stop crying, I lose mom. Totally.
Right.
And I think there's something like that when we have a physical symptom like this, where it's like, if I stop having the physical symptom, now what if I lose the good attention that I have been getting?
Right.
In that kind of situation, that can happen in therapy too, where people will keep coming in and then you go, well, if you stop feeling depressed, then we have to stop our time together. It can be the fantasy, but even just and this is again, part of my responsibility in that situation is to kind of go, that would be sad, wouldn't it? And to say it out loud, I wonder if, it would be sad if you were to not have the symptom anymore because you wouldn't come in to see me anymore, even just to make that talkable is sometimes helps approach that transition towards independence that they've needed to be able to kind of increase their awareness, loosen that hold in some way.
Right.
But all to say, I think it's not, sometimes it's not just, I'm feeling this symptom and it's exacerbated because of my fear about it. It's I'm feeling the symptom and I'm crying out for somebody. And if I stop, then I lose help.
That connection. That's a fascinating perspective. I can totally see that element. When I think about her condition specifically, it's interesting that she does have that connection, right? She really sees me as, well, you're the one that's helping me. And unfortunately, we live in a complex medical system and our healthcare system is flawed, and it's really hard for patients to get the care that they need. And sometimes with these patients, there are sometimes situations where they got physical therapy approved, but they did not get psychological care approved. And so
You're it.
I'm what they get. Yep, I'm it. And I can try my best to communicate and advocate on their behalf. Doesn't always work.
Yeah.
So I can appreciate that perspective in terms of where she's coming from. But it's an interesting thing to contemplate that the physical symptoms are what are working for her right now.
Yeah.
And it's so interesting too that it could even work against her because she hasn't been able to engage socially because of this condition.
Yeah.
She is on disability from work because of this condition. When you look at it on paper, you can recognize that there are reasons that she would be suffering from this.
Yeah.
You would think that she would be taking any advice she could get on how to make this better.
You'd think that she just wants to get out of that position.
Right.
That she doesn't want to have her life be lived this way.
Right. So it's an interesting thing to think about, that she benefits from the role she's playing right now.
Yeah. Usually when we think about, at least from our side, we think about any kind of symptom, we think, what are they getting from the symptom? You
Right.
know, what are
Right.
they receiving from it, to understand that it's a social thing. Any kind of symptom is a social symptom. It's not just an individual symptom.
Right. Right. And what's interesting too is that these are physical manifestations of her symptoms. I have tried my best to educate her that this is a psychologically mediated, socially, emotionally mediated condition. Not that it's exclusively that,
Yeah.
but that is a major component that needs to be addressed.
Yeah.
And she's resistant against that in terms of like, and this has happened with other patients too, where I try to explain, look, there are emotional and psychological elements to what you're experiencing. And I can help you on the physical side, and we can do physical exercises to help you kind of habituate to this or to help you recover from this. But there are emotional things as well. And sometimes they cannot comprehend that. What do you mean it's mental? My leg is shaking.
Right.
Like right now, like my leg is shaking. How can you tell me that this is psychological and emotional? That's not possible. And so again, this comes back to what I was saying about the way that our culture has designed this system, the way that we try to separate the mind and the body. And, the mind cannot control the body. The body cannot singularly control the mind. And so that's why it's so important that we change the language around, well, it's all in your head. Right? Because it's mediated in the brain, but that doesn't mean it's in the frontal lobe. That doesn't mean you're making this all up. It doesn't mean you're malingering. It doesn't mean you're a faker. This is very real. I mean, do you think that you could tell me step by step how you tied your shoes this morning?
No.
No. But you've been doing it for the last, 30 years?
It's habituated.
Right,
Yeah.
it's habituated. It's a subconscious task.
Yeah.
I don't know if I could consciously tie my shoe.
But is it all in your head? Yeah.
Right, it's all in your head.
Yeah.
But it's not like you could. And so in that way, that's an example I like to give of how like there are things that are neurologically mediated that you have no control over.
Yeah.
I'm also not telling myself to breathe every second of every day.
But what people hear when you say it's all in your head is you're just bidding for attention. You're making this up because you want to feel like a victim or something like this.
Right.
And it is really hard. That's really hard because it can sound so invalidating to go, I think what you're going through is an emotional issue, right. And it's really delicate, I think, to work around that, because what you don't want to do is then just go, nope, you're right. It's all your knee.
Right.
Because then that's not helping them either.
Right.
That's hard.
Yeah, exactly. And so that's why I'm hoping we collectively can change the language around that, because yes, there are components of what you're experiencing that are being mediated by your social and emotional state, right? If I'm feeling anxious, I'm not going to sleep well at night. If I don't sleep well at night, I'm not going to have as much, neurotransmitter available or whatever sort of manifestation can exist. And so, yes, these things interplay, but why is that negative? Why is that bad? I absolutely recognize the interplay between my mind and my body. Right. And I have to respect both. And so I'm hoping we can change the language around that.
Yeah, totally.
Yeah.
Some other things I wanted to kind of just mention to see if you wanted to kind of talk about too.
Yeah.
Mackenzie mentioned that you are interested in jiu-jitsu.
Oh,
Is
yeah.
that right? Yeah.
Yes, that's right.
And then also that you also had a paper that was published as well.
Yes.
But I mean, those are very disparate topics, but I just kind of wanted to kind of throw those out there as like, well, first of all, with the jiu-jitsu, I'm thinking about how much of a literally like physical task that is, and how that in your mind dovetails with this interest that you have in the neurologic kind of disorders and the physical therapy piece. But then also curious about your paper. I mean, that
Sure.
seems like notable that it was published or what?
Yeah.
Tell me about that.
Yeah. Well, thank you for asking. I appreciate that. So I'll address the paper.
Yeah, sure.
So I recently had a paper published in the Journal of Neurologic Physical Therapy. It's been published online ahead of print.
Yeah.
Thank you. Yeah. It's in regards to visual postural dependence for patients with traumatic brain injury versus healthy adults. So what we did in my study is we took 20 adults who'd had brain injuries, right, mild or moderate traumatic brain injuries, and we compared them against 20 healthy adults. And we used virtual reality. So we used a virtual reality headset. We had all 40 participants wear the headset, and we changed what they experienced by what they saw or what they heard. So in the visual environment, we placed them in a virtual room of dots, and those dots were either stationary or moving. And then we had either no sound in the headphones, or we had a sound that couldn't be localized. So what I mean by that is, if you were to close your eyes and I were to walk around this room and speak to you, you'd be able to point at me the whole time. You could localize my sound.
Yeah.
But we made sound that was constantly moving around in variable directions that couldn't be localized. And so we compared the postural stability of healthy adults versus people with brain injuries. So we learned something that we knew and something that we maybe didn't quite know, which is in regards to postural control, for you and me, our balance is mediated by 3 different systems. What we see, so I can see that I'm upright relative to gravity. What I'm feeling, so I can feel my hips in the seat, my feet on the floor. And then my inner ear will tell me where gravity sits. So my vestibular organ is telling me that gravity is coming down. For people with brain injuries, their stability, their ability to stabilize is definitely worse than healthy controls. And that's something that we have a lot of evidence to support. But one thing that we didn't really realize is that when we added the dynamic sound, the sound that couldn't be localized, the postural stability of those without brain injuries remained relatively the same, while those with brain injuries worsened. And the reason that matters is because there are different theories for why that's important. But one theory is that if you've had a brain injury, we would call that a diffuse axonal injury, right? There's not one spot. It wasn't a stroke where this is where the stroke happened, one side of the brain. There's injury throughout. And so those networks have trouble communicating. So if I'm having trouble collecting information from the outside world, or even tolerating information from the outside world, I need to get every last bit of information that I can get. And so for them, they may be depending on their hearing to help them partially stabilize.
Whoa.
Right.
Yeah.
Right. Which is super cool.
Okay. That is super cool. It's kind of like, they talk about this with like sensory compensation with like, if you become blind, let's say, your sense of touch becomes that much more sensitive. But this is what you were saying earlier, though, about when people heal from a traumatic brain injury, how you intentionally try to help them build nearby neighboring areas in order to help them become functional again. Right. Yeah.
Right.
But you see that they do that
Yeah.
with sound in order to help them balance.
Right.
Wow.
And I mean, if you think about the anatomy of the brain, that's not even particularly close. The centers that process auditory aren't even necessarily that close to the occipital lobe where we process vision. So maybe it's not even a neighboring structure.
Yeah.
Right? Maybe it's on the other side of the block.
But they're still using it. And so all of the networks and how they collaborate to help us be functional is a fascinating question. That's incredible.
Yeah, very cool.
That's really cool to kind of like to stumble upon that or whatever, to see like, oh, it's actually, this is, how did you know to test for that?
I had no idea. I thought virtual reality is an amazing technology. Yeah. The potential in balance training for people with conditions like those that I see was ripe. I was very lucky to meet 2 excellent clinicians, Dr. Jennifer Kelly and Dr. Anat Lebetsky, out of New York Eye and Ear and New York University, respectively. They were very supportive. They helped me develop this project and worked with me on it. And we ended up discovering something relatively novel, which is why it's going to be published in a impactful journal in my field. Yeah. So very cool.
Congratulations.
Thank you.
That's a huge accomplishment.
Yeah, thanks, man. I appreciate that.
Yeah.
And we'll see where we go with it next, but it's just all very interesting. So thank you.
Yeah. Do you want to do it? Are you going to, I imagine you're going to start planning your next, that you want to keep in that world and doing journal articles and publishing. Yeah.
I do. I think I want to continue writing and publishing. And I love research. I love the nature of figuring out what truth is. I am a skeptical person. I also have benefited greatly in my life from the perspective of, well, I don't know anything. In the sense that, like, when I take the stance of, well, I don't know, it has opened up a lot of doors for me. People have been very kind and generous in answering the questions I don't know. It's given me the freedom to be wrong so that people can come in and help correct me.
Yeah.
But then also it's given me a relative ability, I mean, as best as any human can, which is not very much, to try and be impartial, right? If I assume I don't know, I can probably be impartial about whether or not something works. So, research is the rigorous way to answer that. It is the assumption that I don't know. How do I find out? Let's find out.
Yeah.
And so I do like that. I'm a big fan.
Yeah. Wow.
Yeah.
That's cool.
Yeah. So thank you.
Yeah.
And I can definitely talk about jiu-jitsu. How much time do you have?
Oh yeah. Well,
Because I love jiu-jitsu.
Well, I maybe just suffice to say, I don't know if there's any wisdom that you've learned from jiu-jitsu that kind of touches on some of these things that we're talking about.
Oh my gosh, that's a great question. I think jiu-jitsu's informed that same mindset that I just described of, I don't really know, because jiu-jitsu is a physical manifestation of problem solving. Actually, there's a very important, very influential jiu-jitsu professor, John Danaher, who talked about, he said that the biggest benefit from jiu-jitsu is that it is problem solving under pressure. And he talked about how jiu-jitsu puts you in this state where, as you are playing, right, we would call it rolling. So as you're rolling with your opponent, they are presenting you new problems constantly. And you have to protect yourself, you have to exert yourself, and you have to solve the problem. And it creates a very... Jiu-jitsu keeps you honest. Jiu-jitsu keeps you honest. And what I mean by that is, you can walk into the gym, think you're king of the world, and get your butt handed to you. You could walk in and think, man, I'm so tired. I had a terrible day. And you could get into sparring and do amazing. So there's a truth there that isn't dependent on your feelings. And so that has taught me to be critical. It's taught me to be critical. Okay, I think I know the answer to this. Is that true? Right? Or, wow, maybe I know this better than I think I did because the proof is right here in front of me. So it allows you to take your ego out of it, which I think is a valuable component of research.
How similar is that to the intuition that you have when you're working with a patient like the ones you've described, where they're coming in with a symptom?
Yep.
And they're overwhelmed by fear. They're presenting you with a problem. How similar is that in terms of how you have to hold yourself in those moments to what it's like on the mat, let's say?
So to make sure I understand your question, so we're talking about how that mental space affects my interactions with patients?
Like how similar is the mental space when you're trying to solve a problem with a client to the mental space of you trying to solve the problem that not your client is giving you, but your jiu-jitsu partner, let's say, is giving you? I mean, hearing you say like things like you have to kind of think on your feet. You have to be right present in the moment. It keeps you honest. There's some kind of, I'm guessing, I can't just give up kind of feeling.
Right.
You have to keep pushing through until you find something. But I don't know if it's the same kind of like, I'm sure it's a different level of intensity, like,
True.
but similar kind of mental space.
That's very interesting. I will say one thing that I think would differ is that, jiu-jitsu helps you understand when something just isn't working. And so, yes, there's a resilience component, but there's a calculated resilience. So if I believe something will work, I will push for it very intensely. If I don't think something is working, I've learned through jiu-jitsu, don't fight for it, right? If somebody is working on being in a dominant position in jiu-jitsu, for example, and I recognize that they have all the pieces in place to move forward,
right,
I'm not going to hold on to something that isn't valuable. They're going to progress their position. I'm going to be worse off, but at least now I can present myself with a new problem. But trying to answer a problem that's already been solved against me,
right,
not very useful. However, when I am treating patients, I try to take the same mentality of, I don't know if I know. I'm not sure that I know the answer to this. And so it's absolutely the case where I'll work with a patient, I'll give them an intervention to do, and then it may be my favorite intervention, but I will watch them and see if it's working or not, and have that awareness and that, self-discipline to ask some kind of fundamental questions, make sure I'm not leading the patient. I'm not saying, hey, does this feel great? I say, how does this make you feel?
Yeah.
Better, worse, the same? Is this easy, harder, in the middle? Simple questions that can help me refine the approach.
Yeah.
So by removing myself from it, I can be as unbiased as possible in figuring out what's working and what's not working. And the other thing too is, coming back to our discussion around this functional neurologic disorder, that's a blanket statement. There are a lot of functional disorders. And I think it would be a disservice to take a patient who's having symptoms that we can't explain with our current understanding and just call that functional neurologic disorder. I think that would be premature and incomplete.
Right.
I'm sure there are
We can't just put it in a black box and say, well, we don't know, so let's put it over here.
Exactly. I'm sure there are a lot of researchers really hard at work who are better understanding the nuances of these conditions. And one day they may have their own diagnoses. We may not throw them in this umbrella statement. And so I try to take that same criticism and that skepticism into the work that we do. And that's why I care so much about the other healthcare providers in this space, because I recognize, or I would like to recognize as best I can, when my approach is not working, somebody else's approach is going to be better and more fruitful, and that person should be taking the lead. And I think we're getting there. I think culturally, we are definitely taking a more holistic approach. People are recognizing that this is a team effort, and I just really hope we're moving in that direction.
Yeah.
Yeah.
That's great. Well, thank you. Thank you for coming.
Thank
This
you.
Great. Yeah.
Thank you, Connor. I appreciate this time. It was good talking to you.
Thanks, Dan.
Cool.